you also need to minimize risk. And those two things are usually directly opposite each other. And it may be the same for stuff like an exercise intervention. You may want to test an exercise intervention for some outcome. So you really want to give them the maximum exercise they can possibly tolerate, but that may also be associated with maximum risk. It should be generalizable to clinical practice. There's nothing worse than people studying these interventions that nobody in the world can really do. Either because it takes too much time, too much expertise, or too much money. Now this is sort of in the eye of the beholder, but try to be generalizable to real clinical practice. And then finally, try to strengthen your trial design. If you've got an intervention and you're thinking about different choices, if it'll make recruitment easier, then go that way, because recruitment's one of the hardest things in a trial. If you've got this really cumbersome intervention and you can make it much simpler, and you think that's just as good, you certainly want to do that. Compliance. People cannot comply with, taking a sub-Q injection 5 times a day. So when you're thinking about your intervention, you have to, it's not going to be effective if the people in your trial can't do it. And it's not going to help patients in the world if they can't do it. So you have to think about, can people comply with this intervention? Can you follow them up? Can you follow up on this? And can it be blinded? So an intervention that can be blinded is always better than one that can't, for all the reasons we talked about earlier. I'll just give you one little example of how difficult this is really to think about. I did this trial really early in my career I'm not exactly clear why, how I got involved in this, because it was a little off my topic, but we were struck by the fact that as people get older, they inevitably get weaker. Even if they're healthy, presumably healthy, and exercise. If you just measure somebody's muscle strength consistently over time, by the time people get in their 80s and 90s, they are weaker, and usually substantially weaker. So why is that? And the thinking was that, well, maybe it's because kidney function also declines with aging. And vitamin D is metabolized to the active form of D, 125D, in the kidneys. So maybe, these people are mildly vitamin 125D deficient. People who are really 125D deficient have rickets, and people with rickets are weak. Okay? And you can fix them with vitamin D. So that was the simple thinking behind this. Now, so we were planning to give these people the active form of vitamin D, 125D. And the risks of that are, it's a potent treatment. It can increase the calcium in your urine and in your blood, and that can be dangerous. It can cause kidney stones, and actually hypercalcemia can be really dangerous. So what dose do we use? Well, we didn't have a clue. And so we looked at the doses people use for rickets, and we looked at the doses people use for people with kidney disease, and those range from, say, 0.25 to 1 milligrams given subcutaneously per day. And that normalizes calcium levels in most people with real deficiencies. So we weren't quite clear. We decided to go with 0.25 to minimize risk and see what happened. And then duration, well, how long does it take somebody's muscle strength to get better in treating with vitamin D? We didn't have a clue. But if you have somebody who's weak because they've had an illness, and you treat them with exercise or nutrition, they usually are better in 6 months at least. So we decided on 6 months. And 6 months, people with rickets are quite back to normal within 6 months of treatment. So that was, I don't know, but that's how you kind of go about these things. You have to sort of figure out what the intervention is, and then the dose, frequency, and duration. And sometimes you don't have good data to do this. And this was a problem with the trial, right? What happened? It didn't work. That's most trials, unfortunately. What I was going to say is that the major problem with the trial is you have to put your money down. You might like to say, I want to give 0.25, 0.5, and 1, and I want to follow them for 3 months and 6 months, and I'll take some people who have low vitamin Ds, and I'll take others who are weak, and by that time you can't afford the trial. So typically, you have to put your money down in a trial, and you wind up testing only 1 or 2 questions. And if the answer is it doesn't work, it doesn't mean that no variation of that would work, unfortunately. Here's another one. This was this trial for among people with metabolic syndrome to try to prevent the development of diabetes. And there are actually a couple of studies of yoga out there that show that it might work. So the idea, and the mechanism is thought to be by some sort of relaxation response, sympatholytic response, or something like that. The risks are not big. It's sort of muscle aches and pains. This is restorative yoga, so it's not, you know, half a pretzel-like yoga, but it's a lot of sort of laying around and relaxing. So the dose was to be teaching sessions twice a week for 90 minutes and the duration 12 weeks. But again, you kind of have to use your best judgment to make these things up. Dose titration. So many studies, and you know, clinically, I said this should be clinically relevant. So clinically, what we often do is start with a low dose and keep going until we get a good benefit. And it's kind of like to test that in a trial as well. But it's kind of hard. It's harder to do. Let me put it that way. Here's one in which they treated women with urge urinary incontinence, and they randomized them to Detrol, which is now approved for treatment. You have a milligram twice a day or placebo, and then if after 3 weeks that was inadequate, you'd go up to 3 times a day. And everybody, you know, if you're in a placebo group and you didn't get you had inadequate relief, you go up as well. So you just raise both groups. So that's the kind of common way you titrate a pill anyway. And you could do the same thing with a behavioral intervention by starting out at a certain, say, a half hour of exercise and going to 45 minutes or something like that. You can also use several doses of a drug. This is commonly done in phase 2 trials, where instead of just randomizing to drug and placebo, you randomize to drug dose 1, drug dose 2, and placebo. This is the multiple outcomes from the Loxapine trial, which tested raloxifene for prevention of fractures, and they randomized these women to 60 milligrams a day or 120 milligrams a day. This is good because it helps you identify what might be a better dose, and in this case that worked because the 60 milligram dose was just as effective as the 120 milligram dose in preventing vertebral fractures, and you may as well use the lower dose, thinking that will have fewer side effects. Sometimes you can show a dose response effect so that it's clear that some people get a good relief on a low dose, but some people need a higher dose. The drawbacks are that you need more sample size, right? So if you're going to really compare 2 active doses, each one to the placebo, you tend to need somewhere in the order of about 20 to 30% more participants in the trial. And the analysis gets more complex because now you have multiple comparisons. So in some ways, a simple, you know, active placebo-controlled trial is the easiest to plan and to carry out and to analyze, but these others have some advantages. Then there's the multiple intervention ones. One of the classic ones of this was called Mr. Fit. What did that stands for? Oh, multiple risk factor intervention trial. And this was a trial many years ago where men with heart disease were randomly assigned to sort of a smorgasbord intervention. They got smoking cessation, lipid control, dietary information, exercise, and compared to usual care. But the problem here is that, well, that one didn't work. And then the Ornish regimen is very much the same. You know, you guys know who Dean Ornish is. He has an institute in the East Bay where people go to get this sort of training to prevent coronary disease. And it's a combination of, you know, you do yoga for about 2 hours a day, you eat a 7% low-fat diet. Of course, none of those people smoke. They get, you know, the whole big intervention. And it's not entirely clear if that works either. Multi-drug HIV therapy is kind of the same, though, right? We give people 4 or 5 HIV drugs compared to 3 or 4 different ones and see what works. Those of course do work. The advantages are you maximize benefit and mimic clinical practice, but the disadvantages are expensive, it's cumbersome, but mainly, if it works, you don't know what worked. Mr. Fit, for example, if you had to do all those interventions and it was only the smoking cessation that was responsible for the benefit, you really haven't answered the best question. And then finally, some studies insist that you add on to a background sort of standard of care. This is very common, for example, in studies of treatments for congestive heart failure, where we already know that 4 or 5 things prevent death and hospitalization in patients with congestive heart failure. So almost everybody with congestive heart failure should be on a diuretic, an ACE inhibitor, a beta blocker,